is here, so she oversees all the benefits for VA in Nevada. Ms. Peggy Kearns, who is the director of our VA Southern Nevada Healthcare System, who oversees all the healthcare here in Southern Nevada. And then we also have Dr. Ramu Kamanduri, who's our chief of staff for the VA Southern Nevada Healthcare System. And Dr. Kamanduri actually sees over all the operational medical activities that happen here within the VA Southern Nevada Healthcare System. So what we're going to do is we're going to turn over to Ms. Jackson for some opening comments, followed by Ms. Kearns, and then we will go from there.
Thank you very much. As always, I'm happy to be here and to have these discussions with you. Every single time I get a chance to stand in front of you and be accountable to you, then I'm happy to do that. So any questions that you have, I'll ask them, but I'll also be around after this. If you need one-on-one talk, I have your stuff. I'm good with you. But if anybody else have any specific questions, I have business cards, and I also have my regional office staff here. I've been trying to change for now 20 months the fact that I'm Reno Regional Office when I'm actually the state of Nevada's regional office for benefits. It's it's crazy. I'm here in Las Vegas. Why would I say Reno? Nevada Regional Office. All of the staff calls in Nevada Regional Office because we're concerned of any veteran issues that you have. We're here to serve you. I have my Kelly Stellman, who is the officer in charge of the entire Las Vegas office, and then the management analyst, Pete. I do know your last name. I really do. Is this Pete? Okay, Pete. Takes care of keeping us all in order. So if you have any questions, welcome to your town hall. And I really do thank the director and my counterpart, VHA, for putting these venues together. We've seen a lot of veterans touch a lot of lives today, and that's what we do for a living. So thanks for coming.
Thank you.
Yeah, thank you, Ms. Jackson. Today, I don't know how many of you were here earlier, but today from 12 to 3, we had a veteran hiring fair. And it was part of our Veterans Community Engagement Board, which we partnered with over 50 different agencies in the Las Vegas area. And they put together this hiring fair. We had 250 people show up to the hiring fair. And they had jobs ready. So it was very exciting to have everybody show up. The companies that came were very excited that we had so many people come, and the idea was to find jobs. So I think it was a good success today. Next town hall, we'll have some numbers for you on how many people got jobs as a result of the fair we had here today. So we're excited about that. So today, I just want to go over a couple things. You all know we have a new VA secretary. His name is Dr. David Shulkin. And he was the undersecretary for health for Veterans Health. He's now the secretary over VHA, Veterans Benefits, and Cemetery. So he has 5 top priorities since he came into office. One is greater choice, which means he wants to offer the choice out in the community for care when we can't provide it quickly, and or if you live too far. There are going to be quite a few changes to the choice program coming up in the fall. The things we know so far is that we will take back in-house the scheduling of outside appointments. We used to do that, and a third party was brought in as kind of the in-between to make those. We're going to be going back to where we make the appointments without an intermediary, which I think should help our timelines. He wants to modernize systems. How many of you have heard him talk or seen in the paper about getting a new medical record? Yeah. Well, the VA medical record started in about 1980. And so it's old. And so we need a new one. So they have selected a company called Cerner. They do a lot of the private sector healthcare, and DOD has contracted with them. So that's going to be probably a 7 to 10 year conversion to the new system, but we're excited that that's coming. He wants us to focus resources. So one of the things he is looking at is what should VA be doing? What should the services VHA should we be providing? Primary care, of course, mental health. But what beyond that should we be providing? So that's something they're working on at the highest levels as to what that should come about. Improving timeliness, that's improving how fast we can get people in. This valley, I've said before, in these town halls is very difficult to get care out in the community. The time frame you have to wait is not unusual to wait more than 30 days out in the community. We work really hard at improving our timeliness here. We have some numbers for you on the next slide, but that is still this focus that we continue to see people quicker. And last but not least is this program on preventing suicide. Much like getting to zero in homelessness, which we accomplished here in Las Vegas, we got the functional zero. Doesn't mean every veteran has a home, but it means they could. We have vouchers for them to get homes. But with suicide prevention, we're going to be working collaboratively with the community. And we're very lucky here to have our community engagement board that we'll be able to partner with and work on preventing suicide. So you're going to hear more about that in the future. So some of the interesting facts for this year so far. We have seen 56,819 unique veterans so far this year. And we're on track for about a 5% growth over last year. We've already done 671,544 outpatient visits. That's up 30,000 from a year ago. Our average wait times, 90.99% are scheduled within 30 days. It still leaves 10% that we're not scheduled in 30 days. We're working on that. For an established patient, average 3.7 days for primary care, 12.5 for specialty, and 6.9 for mental health. We've done 29,500 emergency department visits already this year, and our average door to triage is 7 minutes, and door to doc is 18 minutes. We've done 4,201 hospital admissions, which is a little bit less than last year. But more of our care is being seen as outpatient rather than inpatient. And we've taken nearly 900,000 calls. So when I know it's a frustration for our veterans that you can't always get through on the phone, it's a large volume of calls. But we are working on hiring more people and getting that improved. So, one thing to remind you, we've talked about this at town halls, but I just wanted to put it out there again because we always have new people that come. If you have a need for primary care mental health, we can date you in the same day in our clinics. We do have that availability. So if you walk into the Northeast or the Northwest clinic and you need to be seen, you'll be seen. It may not be by the doctor, it may be a nurse, it may be a social worker, it may be, those are choices, but it depends on the need that you have for that day. And of course, we do have our ER here, and we do see people in what we call fast track, which is when you're not quite sick enough to go to the ER, like urgent care. It would be more comparable to that in the private sector. We do have a new app. The app allows you to make appointments, allows you to make primary care appointments on the app and to request a mental health appointment. Okay, so you can't make the mental health appointment, request one. This though requires you to have a certain level of access through e-benefits. So you need to have the level 2 access to that. We do have veterans already using this, and I think we're going to see more and more of these things go to the newer technology where you can do it from your app, from your computer, from your phone. For those of you who want to look at access, quality, our quality numbers and how we compare to the community, there's a new website. It's www.accesstocare.va.gov. That is out there. I will tell you our wait times are on there, so you can see those. That's updated like every 2 weeks. But the information on quality is from 2015. And part of the reason for that is not that we don't have the information from 16 and 17, but it's matching information from Medicare, and Medicare's information is that far back. So when you look at that, make sure you realize that you're looking at stuff 2 years old. We've made improvements. So have the other hospitals in the community made improvements. Okay. Now this is a new opportunity. I'm not going to call it benefit. I'm going to call it a new opportunity. And it allows, it was legislation that allows other than honorably discharged veterans to get emergent mental health care. Okay, that was not allowed before. They have to access this emergent mental health care through our ED or through the Veterans Crisis Line. This is a time-limited benefit, 90 days. And if we're not done with treatment that time, we can extend it another 90 days, but after that, it goes to be help transition to the community. So this is a new benefit. There's about 500,000 other than honorably discharged veterans that could be eligible for this. So I'm not sure if we've seen anybody under this authority yet. To my knowledge, we have not here. But it is another opportunity for people to get care. And this is all part of the suicide prevention push that we're going to see this year. All right, well, this is kind of a fun thing. We have a Veteran and Family Advisory Board. I'm going to invite Jennifer Garrett to come up and talk about the group and introduce those that are here. But this is a picture of the group and their names. So Jennifer?
Thank you. So I'm very excited and very honored to be working here. I started here in April. Very excited to get here and happy to be here. And then I got here and I got told that I get to be working with this group every month and it did even better. These are an amazing group of people. They're lively, they're energetic, and most of all, they're passionate veterans for veterans healthcare, your healthcare, their healthcare, and they're very open and willing to listen. So we all smiled ready for a picture one day, and they only had to take like 4 to get it to work. So we've got Jerome Adams, Cindy Edmondson, wait to us, Jack Ford, I think he's here, Manny Garcia, Manny's back there, John Kennedy, Edward Wright, and Ken Shobley. What we're going to do is we're going to establish an email group so that veterans can contact this group directly and you guys can communicate directly. We want them to be another voice of the veterans so that you can talk to a veteran about some of the challenges and issues that you're having, or compliments. We like compliments too, so I don't want to take up too much time, but this is your group. Oh, I guess I did do this later. So, as I said, they're the voice of the veteran. So we really want to make that available for you guys to all reach out to them. They're here a lot. You know, some of them are here more than others, but you'll see them around the medical centers, some of the clinics. And the Gmail group should be set up pretty soon. I'm technologically challenged on that particular aspect, so I'm working with somebody to get that done, but we should have that done by end of the week, maybe get next week. Anybody have any questions about it? I'll be here, I'll be sitting over there, and some of the members are back there. So if you want to talk to them directly today while you're here, please feel free. I know they'd love to take some questions and would love to get some suggestions.
All right, thank you, Jennifer. And as Jennifer said, she just joined us. You know, she's a little modest there. She joined us in April, but she has been putting together a team to kind of get a lot of these veterans experience issues. She actually has a new patient-centered design specialist who started with us, new system redesign specialist starting soon that can help us with some of our processes. And she's been working with our patient advocates and our other people on that veterans experience team to try and improve that veterans experience. So Jennifer, thank you and welcome. So this is the moderated town hall portion of this, and as we said, this is a moderated Q&A session because in the past we've had veterans ask us, say, hey, we come to these town halls, but in the past they were just frankly shouting matches, and people were walking away without being educated or receiving their health care benefits. So we want to make sure that we do that. So if you have a question that you feel like is either for the big crowd here that we can ask, or if you have a personal issue or something we can ask you to fill out one of those comment cards. John Scott and David Martinez are in the back. Just raise your hand and they'll bring you a comment card. And if the question's of general interest, we'll try and get to that during the session. If it's of personal interest, we'll take that card back and staff it with the specialist and get you an answer back by the end of next week. So that's the thing. And then also we do have our veterans benefits people here for claims and clinic. So if you have a personal benefits issue, they are right outside the door. They are happy to help you one-on-one. So please feel free to go out there and do that. So. All right, so I'm going to talk about some of our questions that were submitted in advance, and I'm going to get to a few of the cards here. So I'm going to start with Ms. Jackson. So Ms. Jackson, we recently heard on the Hill, we heard Secretary Shulkin talk about something called a decision-ready claim and how we can get claims approved in a matter of days now with certain items, but the claim has to be decision-ready. Can you kind of explain what a decision-ready claim is, how that works, and what a veteran needs to do to maybe get considered for that?
So, yeah, sure, thanks to the DRC. You know, we have a lot of acronyms. We had FEC, which was fully developed claim that really launched heavy in 2012, and we promised to be able to process a veteran's claim from beginning to end in 45 days. Beginning to end means that you submitted a claim and you said, because of my service, I was injured or I was ill in this way. It starts, we ingest that into the system, that's one thing. Then it moves over and we gather evidence to substantiate what you said actually happened. And that's another period of days. And we had some legislative time in between that. At first we had to wait 60 days after we sent you a letter that you couldn't understand anyway. But we sent you a very complicated letter, and then we reduced that letter to just telling you, yes, we received your claim, and now we're going to take 30 days to be able to process your claim. That's 2012. And at that time, it took veterans benefit an average of about 18 months from beginning to end, because we would request an exam from the medical center, and then when that came back in, it went into the list for about another 6 months, and then you were able to finally get a decision from 18 months to 2 years. That's where we were in 2012. And then we had a fully developed claim that said, well, let's expedite that to 45 days, and then we started dealing with, let's dive down the backlog, which was defined as more than 125 days to deliver a claim to you. 125 days is a lot shorter than the 2 years. And so everybody, Congress, everybody began to furiously drive down the backlog. It was very interesting to me as being part of that to realize that how quickly a mortgage can get set. Now it is absolutely criminal to have a claim past 125 days. If veterans are waiting more than 4 months, we feel very inadequate that we haven't delivered you good service. But we never stop trying to get the voice of the veteran. What you said is, I want a decision on my claim quickly and accurately. And quickly was defined for you of even faster than 125 days. When Secretary Shulkin, as the director told you, came in, he's very energetic, very action-oriented, and so someone came to him with this idea of decision-ready claims, promising to get this claim done for you in 30 days. So immediately he said, well, let's test it. So they tested it in May in St. Paul, Minnesota, and with, okay, how long do we have to run this pilot? This is a very actionable secretary you have right now. And after 2 weeks, they said it was working fine, so we said expand it. Then it expanded it to Waco and Houston, and it was still working. And so this is this year, 2017, how fast this moves under our new leadership. So since it worked in those 2 places, he now is directed for full-blown implementation of that decision-ready claim, and it will affect the Nevada Regional Office. We now have a mandate to have decision-ready claims for you by the end of July 31st. And so what that means is that you go to a BSO, that you and that BSO work in partnership to get every single thing you need to file a claim for an increase. It's rolling out initially with just the increases. If you got worse, your service-connected injury has worsened, and you and your BSO get together and tell them that it's worsened, the BSO requests the exam. You come to the VA with, okay, I have an exam, veteran is worse, here's my evidence, write the claim, and we promise to give you that claim 30 days or less. Of course, if you're in Nevada, we'll give it back to you 20 days. I mean, just saying. But the idea is that we're constantly trying to improve our services to you from the voice of the veteran. And you say you want more speed, more accuracy. Accuracy is even more important than the speed. Please get my claim right and get it to me. And I just love the fact that we're never going to stop. I don't know if it's not, we're not at same day. We can't do same day delivery claim. Wouldn't that be wonderful? But we're going to continue to do what you tell us you need us to do in order to honor the service that you've already given this great nation. So essentially, that's an overview of it, but I encourage you to get with your Veteran Service Organization officer. If you have a claim that has gotten worse or you need an increase on your claim, try this process. It really, really works efficiently. Okay.
Thank you. All right, before I move on, Ms. Kearns kind of alluded, she talked about the Southern Nevada Veterans Community Engagement Board, which is a group of about 50 different organizations that come together to work together to put on things such as like that hiring fair today, Health and Wellness Fair we had back in May with our town hall. I was a little remiss, I wanted to just introduce Nina Ridgway in the back there too. Nina is the chair of our Southern Nevada Veterans Community Engagement. So Nina, thank you for joining us as well. So this one's kind of a follow-on to what we were talking about. This might either be a VBA or VHA question. I might ask Dr. Humphreys Jackson to tag team this. The question is on, other than honorable mental health visits, are the vets being set up for discharge review or possible updated discharge other than that 90-day period to see if their other than honorable condition was charged, could have been a result of that mental condition?
Well, first of all, you don't have to be in that program to request an update to your discharge or to get it upgraded. You simply see one of the counselors, VSOs, work with us to see if we can get the discharge upgraded. There's also a way that we can administratively review your discharge and see if for VA purposes, we can grant you honorable for that, depending on the facts and circumstances of your individual case. But I wouldn't wait till be submitted or admitted for this program to try to upgrade it. We can do that at any time. In fact, I can talk to one of the counselors to get that started out there today.
Great. All right, and then this is kind of something we've seen a couple reports on here locally lately in that, and kind of a question we get. If a veteran seeks care outside of our VA in a downtown emergency room, what is the policy for that veteran to make sure that the VA is notified? Is there certain time frames, like 72 hours?
We have that. There is a required notification from the community hospital. The other thing that we've done, really have a robust care in the community program. And we have our staff interacting with every community hospital in town, just so we're aware there are veterans there and we communicate with them and have a link issue. So we make sure that link is made so that the veteran's not left hanging with the payments and other costs. That is really, that's a challenge all over the country. But also it's the emergency care portion that is covered, so that those portions are not very straightforward either, so we continue to work with agents.
Outstanding. And so it's real important then also for the veteran or the family member to notify the hospital that they're a VA patient as well. Correct. Thank you, sir. And I think Dr. Converia, this is kind of probably a good follow-on, is we've seen a lot lately about pain management. We've got a couple of questions here about holistic therapy and pain management techniques. With the opioid laws that are kind of changed in the nation, what are we doing here at the VA locally and nationally to kind of, one, address the opioid epidemic issue, and two, what are we offering as alternative means of therapy, be it holistic or otherwise, to help veterans with pain needs and issues?
Again, I want to first thank everyone for coming out here, and thank you for your service, and thank you for allowing the VA to take care of you. So it's a great honor for us to do what we do to take care of the veterans. And I can tell you, we've really seen a major change in opioid use and prescription. Southern Nevada has a horrific problem with opiate addiction. And as you know, there's been a tremendous overprescribing in this community. Right now, prescription opiate overdose deaths far exceed car accidents and many other forms of death that's happening every day tragically. So many folks are dying from prescription opiate overdose all over the country, all over the world. So what can we do? So several things. That the prescription pattern is changing. We work on our own. We have a tremendous pain management program with Dr. Isani, who manages the program here. And we do a comprehensive pain care. So everything from very aggressive interventional pain, and so we like spinal cord stimulators and implant, those kinds of things, to providing really many unique alternative therapies. We're actually one of the few VAs that uses a program called Alpha Stim. And it's a program, it's a device you actually fit into your ears, and it goes after alpha waves and it helps people with pain. It's been considered very beneficial. We're one of the VAs that's been approved to use this program, and we use that. We also have now introduced a yoga program. We have, just for pain management patients, we have introduced Tai Chi for folks with pain and mental health conditions. So we are doing unusual, different approaches. We have one of the most comprehensive treatment for acupuncture in the entire nation. So we're well established. We do acupuncture from head to toe, so we do all kinds of acupuncture treatment. So we are using these novel and additional complementary therapies along with just prescription medications. And we're also changing how and what we prescribe pain medications, and just because historically we've gotten such aggressive use of opiate medications all over the country, that's led to this problem from everywhere. So that is a pattern of changing. We're working with our providers to change how they prescribe and use medications.
All right, thanks, Dr. Comanduri, appreciate that. One question that we have, and I'll just kind of a follow-up for you, Ms. Jackson, you had talked about the decision-ready claims. The other part of that is the appeals, and we've also seen some legislation and things moving on the Hill, maybe in regard to appeals. Can you kind of address what's going on to try to speed up appeals nationally and locally?
Okay, yes, Congress just passed the Appeals Modernization Act. What that's going to do is sort of centralize appeals in Appeals Management Office out of Washington, D.C. But your local appeals will give you a choice. If you want the new Appeals Act, then they can guarantee you that you're going to have to just submit all of your evidence within like a 90-day period. And then you can be guaranteed that your appeal will be finished within that year. Currently, appeals are taking anywhere from 5 years from Veterans Benefits Administration, a 5-year waiting period, and which is just unheard of for you to get an answer for what you're saying that you disagree with a decision that your initial decision. So the Appeals Modernization Act is going to affect all of the timelines. Everything can be legislatively moved faster. For instance, right now, if you file an appeal to me, I can't do anything to that appeal until a 60-day period has passed. And once that 60-day period has passed, if you bring in additional information, then I have to give you another 30 days before I can even issue a decision. This is not a waivable legislation. This is the law that we have to do in order to adjudicate an appeal. And every time that you go to a doctor or you add additional evidence, I have to add another 30 days before I can even send the appeal forward. This is just at the regional office. Then in order for me to send it to VACO, it's been on the regional office for now going up to a year. When it gets there, it goes on the docket. And the docket right now is back up 5 years before they even look at it. And so in order to relieve that appeals process, we try to resolve your appeals here at the local area. We work with your veteran service representatives and VSOs and with you and try to come to a resolution here so that it doesn't go into that BBA. But the Modernization Act is allowing for more appeals personnel to be hired, and it's a whole extensive fact that's going to give you another path than the traditional way that we have been doing appeals. All again, as I said, with an effort to stop having you wait so long for a decision that you deserve. So everybody is working and Congress is working with us. In fact, some of your local Congress people were also co-sponsors of that. And Ms. Tiger's Ribbons behind it and allowing us to do that. So it's just passed in June. I'll have further information on how it individually affects the individual appeal, probably before our next town hall, but for sure I'll readdress it again at that time and tell you how we're doing.
All right, thanks, Ms. Jackson. All right, so one question we have here, and I know this is probably not just us, but our community partners involved in quite a bit, is what are we, VA community continuing care to move out the number of justice-involved veterans slipping through the cracks from both from arrest to court within the court system, and I guess so. What are we doing within the court system to help our veterans, and then what are we doing to help our incarcerated veterans reintegrate?
We actually have a very solid West Veterans Justice Outreach program. We have actually multiple counselors reaching out to various veterans who are involved in the justice system. Now, one of the things, if a veteran is incarcerated, the VA cannot, by legislation, cannot provide health care or healthcare services while the veteran is incarcerated. Once they get out, they're eligible, obviously, you can take over the care. Now, while they're incarcerated, our staff has gone and worked with them. In fact, many of them even filed to talk about upgrading their discharge. We've been working on that. A lot of folks also from there can file to upgrade their status and increase their service connection or even seek service connection. So that is being done. In fact, we have folks from our own facility that actually go and do some exams. We've done it with the justice system into the jails. Our own doctors here have gone out into the jails and have done compensation and pension exams so a determination can be made for benefits to the veterans. So we're doing that. The other, I think, exciting part that we've done is we're one of the first VAs that actually established a veterans court, so that the veteran that's involved in relatively minor offenses where we can help them detract from a jail term and get them into counseling, or if it's alcohol or drug abuse problems, get those services in place. We've been working with that. In fact, one of the judges is actually coming out to meet with us in the next couple of weeks just to look at how we continue to coordinate this here.
Thanks, Dr. Convery. So these are a couple like kind of facility-related questions that I'll hit them both here. One is kind of asks why there isn't security posted at the entrances. Do we want to say anything?
Well, there's security around the facility, so they have a regular schedule. They go around and make sure that we're safe. So we don't have people posted all the time, and we also have people who you may not know are policemen up there for us. So you know, we don't have what do you call it? We don't have metal detectors, so we don't have people posted.
And there's quite a few cameras.
Oh, yes, there's many cameras.
Big guy is always best.
And then kind of part two is, and this is probably like a suggestion question. They were asking why there isn't a motorcycle parking area on the north side of the facility. I'm not sure if there is or isn't happening out there. North side over here as well.
We can look into that because we don't have one, because I don't know. We have one in the back, but that's mostly employees using that, so I'll have to look into that.
All right. Dr. Convery, probably with your background, you might be the best person to answer this question. And this comes from a Vietnam-era veteran, or probably Vietnam veteran, was kind of asking, you know, what's being done here at the VA locally to ensure that when Vietnam veterans come and visit our facility, that they aren't, there's a mental health, that there isn't a mental health stigma, or they aren't labeled as, you know, with such a stigma there, I guess. I think that's kind of what the question's getting at. It's like that personally feel like there's a sort of stigma that there's what do we do to educate our employees and staff to assist our veterans?
And I've been really lucky to work with Vietnam veterans since 19 '83, so you can imagine a long, long time when they first started working with us. So I've been very fortunate, blessed to have taken care of many, many Vietnam era veterans, and certainly World War II and other generations. And the stigma is been, it's not entirely, continues to be stigma to seek mental health care. The vast majority of folks with mental illness sadly never seek care, are never evaluated, and never achieve care. That's a tragedy in our society. They never even come out and get care. So what we are trying to do is, how do we reduce the stigma? One thing that we have in our primary care clinics that helps is we have mental health integrated into the primary care setting. So we can go to the clinic, no one is looking at like big sign, mental health clinic, where you can get mental health care services. You're actually just going into a clinic and no one knows specifically the type of care you're getting, which is one way to reduce and prevent the stigma. Overall, we have to also generally reduce that thing of fear of not seeking help. We see this with many veterans. Veterans are strong and dedicated folks sometimes feel like that they don't want to come in and seek this type of help. So our staff has to be acutely aware. Frankly, our staff probably needs more mental health care training than most other settings. We see a lot more folks with emotional conditions, but both our hospital staff and outpatient staff are familiar with it. We actually constantly train our staff on looking for suicide, looking for mental health issues. So we continue to do that. So we hope there isn't the stigma when somebody walks in the door.
And part of the new suicide prevention materials we're going to be coming out is more training for our employees to learn how to identify and what to do if somebody presents suicidal and how to get them help. So that'll be a big training effort that'll start in the fall.
Great, thank you. Okay, this one's another medical related question. And the question is why is it that vets are required to use choice for allergy shots when we have an allergist doc at the VA? And so that I guess it just can't question mark get this room. So
sure, that's a very good question. It's interesting. It's a complex issue. With allergy shots, in fact, the allergens you have to apply, they're restricted how you can get access to them. They're not easily available. They're restricted by license. How we get them in the federal government. So that's been a real challenge here, is to get them. What we have been working is ways to get through contracting and government means to be able to get that. It's not been easy. We're even working with our Nellis partners. And so we have finally been able to get some access to be able to do the shots. So, and that's been, but unfortunately I have a piece of bad news. Unfortunately, our only sole allergy physician is actually leaving in the near future. So that's clear. We are looking, and we actually have a new allergy doctor coming on this fall. So hopefully, once that doctor comes on, and now that we have actually the testing materials, we should be able to take more of the care in here. I think it would be better if we could do the care in-house with those shots.
thanks, Doctor. All right, Ms. Jackson. So this is a question we pretty much get anytime we do a public forum or a roundtable when our VBA partners are there. Is everybody always wants to know about, I guess we call it the compensation math or the disability percentage calculation and that, for substantiated claims. Could you kind of talk about how that's done and what the process is?
Amen. I love it. I was reminded at a town hall for Senator Heller that it really wasn't VA math. You can't take the credit for creating 40 plus 40 plus 20 plus 30. That's not equal 120. It's actually 80, right? But Kelly, you want to come up and tell them there because she doesn't know. I won't put her on the spot. She just gave a class in it, so I'm just going to put her on the spot. That's okay. I'll tell you my version, which will be the simple version of the way this works. First of all, I don't know how to make you more than 100% amazing. I don't know. You're only one person, and I don't know how to make you one person plus 20% of another person. I can only add you up to 100%. So what I'm trying to say is, if you have an arm that is disabled, I think that you can't get viably employed, you can only do maybe, that's 20% of wholeness that you work. But if your leg is good, that may be only 40% wholeness that you are. But understand, you only got 2 of these and 2 of these, I can't give you 3 of them. I can only give you a whole person concept. So the intent for getting a disability rating is how disabled are you? How disabled are you to be fully employed? This is the basis of where that percentage came. So if you are 40% and 40% and 40%, that doesn't make you 120% person. I might make you 100% whole because that's the max I can go to in a whole person concept. I can't get more than 100%. So all of those figures that add up, but I will tell you that it is important. If you had service connection for 5 40s, you know, of course that's not 200, but each one of those 40s are an individual entitlement. In other words, if in fact, say that you had, you passed and the reason that you passed may have been one of those percentages. If you weren't service connected from any family member or widows, which we'll discuss that in your widows, you may not be eligible for some compensation because you didn't have that particular injury or illness service connected. So even if you are 100% and there's something else that presents to you as a disability, you still want to go because if it is rated, then it becomes part of why your disability is there. And if not for you, your dependents or your survivors could benefit from you getting service connected from that injury. So I don't discourage you to get all of your little pieces together, but we can't pay you more than 100% of a whole person. So no, how many disabilities you have, they can't add up past one whole person, 100%. Okay, so there you go. See, you would have done better with your LMAF.
Great, thanks, Ms. Jackson.
You notice how I read that? Please not me.
All right, I'm going to try to read this one. So it says, I want to know why the VA does not let veterans know if they are qualified for Social Security, Medicare Parts A and B, and also VA medical benefits, and an outside medical provider for whatever, and are charged a deductible for a copay. What is the VA telling they can file a claim with Medicare Part A and those costs may be paid. Says many veterans may not know that they may have been paying these costs, and they just want to know, does the VA do anything, or can the VA do anything to educate some of our veterans who are qualified for multiple different things, how to address those things?
Well, they don't integrate. We can't bill Medicare. So VA and Medicare are two separate things. The most important thing is something we talked about at the beginning. And one of the questions was, if you are in facility and hospital, you need to let us know within 72 hours that you are there and that you're a veteran. Then VA will pay. If you claim your Medicare, then you claim Medicare, and we may see some changes in that in the future, but at this point, there are two separate systems. I don't know if I answered the question, but they are two different things.
We might take that as for an education thing, maybe with our Veterans Community Engagement Board, Social Security, and Medicare, maybe we can have a session or education session on that.
Yeah, we can have a session on that. That would be good. Yeah, because that's we don't deal with Medicare, so I wouldn't want to give you any answers towards that.
I'll say we'll take that for action. So Dave, if you want to scribble that down. All right, one question here. This is from a caregiver who apparently has been trying to get into some of our classes here recently, but they've been canceled to due to small attendance. And then this individual also says there's a couple of other type of classes that have been canceled recently due to the attendance. Is there anything we can do for people in those situations? Do we have a certain limit or something like that we need to do to hold a class, especially for the caregivers?
Yeah, let me follow up and we find out what the size that is and that type of class. Even if the size is small, we could still hold that person if he's good with that person. So I don't necessarily think we have to wait till X number of people enroll to do the class.
Afterwards, if whoever wrote this, especially tell us what classes they were, because I've seen classes when we saw 203 people. So I would like to know what they are so we can go back.
Well, I know who the person is, I'll see if the individual's here, if not, we'll get them in contact. All right, this one's kind of gets back to the holistic medicine approach. The question is, and I think I know the answer, but Dr. Humber, I'll let you answer this, is kind of, is talking about hyperbaric oxygen treatment chambers. They're asking if the VA has hyperbaric oxygen treatment chambers, or do we actually send out this type of therapy?
It's an interesting point. Like any new technology, people say, well, it comes out, is it good for everything? I mean, perfect example, just the other night somebody posted, I have migraine headaches, so should I go get marijuana? Well, I guess people, there isn't necessarily evidence to prove it cures your headaches, and there isn't the data, but everybody believes, well, why not? Because now it's legal, so to speak. So, not saying it doesn't help some people, it may really certainly help their migraines, and may help for other things, but there isn't that rigorous medical research to support everything. With hyperbaric, there is some limited benefits. Clearly, you can use it certainly for wound healing and certain factors for that, obviously. But there are things that people talk about. Some people say, well, hyperbaric can help with, let's say, traumatic brain injury. That has not been strongly proven with the data to support it at this stage. So, unfortunately, many of the purveyors of these products will say, oh yeah, you can use it for anything and it'll cure everything. So the challenge is the data is not there to support it. We do use hyperbaric in cases of referral where we think there is a true benefit to it.
All right, thanks, Doctor. All right, Ms. Jackson, this is another one for you. And you and Kelly have talked this one in the past, but it kind of gets back to, you know that there's been some presumptive things that happen in the past. We've seen Agent Orange, we've seen Camp Lejeune recently. And a lot of vendors kind of asking us, and this is a two-part question, this probably recent ones. One is Camp Lejeune, why aren't there more maladies that they can qualify for? And then part two is there was a veteran that asked a question about exit report development or another location like that. Why can't they kind of be considered for the same type of presumption?
Okay, so I'm never going to disagree as to why can't, but I do know that it's up to the secretary to decide what those diseases are and what something are. Camp Lejeune is still under study, so that's not the end all, but the decision was made so that we could catch the veterans that were in crisis right now with those presumptive that we've proven that could have come from the contaminated water. I understand Fort McClellan question since I was stationed there for 4 years as a chemical specialist. I do understand that why wouldn't that be included, because I was tested with my agent on my state as the class, so I do get the connection. But it has to be scientific medical evidence and enough data to prove the preponderance that it is a causation, there's a causality relationship to the exposure in Fort McClellan and the current disease you might be facing. But I don't give up hope, because VA is constantly researching, and the scientists is continuously trying to make those linkage and causation relationships. So I keep my faith on that, but until it's legislated that they added another particular disease or illness, there's nothing we can do to indicate that, but I understand the sentiment.
Thank you. So this question is kind of a caregiver related question too. I think it's going to be pretty much, doesn't need to be a caregiver, it could be a family member, it could be some concerned person in that. The question is just kind of like, what can be done to help like caregivers and of veterans, get their loved one or their friend into mental health care when they see that what can we do to help them get into mental health care that they're maybe seeing a psychosis or something along those lines?
One, obviously, we need to be able to, first of all, we need to be able to openly discuss these things. When somebody is suffering from these conditions, there's a tendency for family members, caregivers, just to say, well, we don't want to talk about it because they feel like there's nothing they can do. But there's a lot we can do for people with mental illness. We can get them help. So one issue is we need to get the veteran who's having issues, definitely get him into care, get him into mental health, and coming in. Another thing is we have to recognize, and one of the things that we ask in our own primary care clinics, questions, are you suicidal, are you depressed? We ask these things. So just so, even if you're not going to mental health, do we make that referral, make that connection? So we do that. The other part of it is this seems to be a question about what happens if the caregiver is having issues, which is a huge problem. I will tell you the burnout and the stress among caregivers is unbelievable because especially when you take care of somebody who is suffering with severe physical, mental issues that are so complex, and when we see increasing numbers of patients with memory and cognitive impairment. And so if the patient who's got memory problems is 70 years old, oftentimes their spouse is also 70 years old. So now you have an elderly person trying to take care of an elderly disabled person. Very difficult to do. But what we do have is a respite program. So we can have a mechanism, have a break, so that the veteran could go into a respite type of program for a period of time, and then they could get help for the caregiver. So we're working on those cases where people have cognitive and mental problems to be able to be away, even to have a break. We also have some home health opportunities where somebody, caregiver support person can come into the house. That way the caregiver has a little break. And so some of it is based on eligibility, but these are all resources that are available. But the burnout and the stress of caregivers is just truly amazing.
Follow on with that real quick is what if the veteran doesn't want to seek that help and the family member or the caregiver knows that they need that, especially at mental health? What do they need to do?
Yeah, and the veteran doesn't want to seek help care, and they certainly they need the mental health service. One way the caregiver can approach it in a different way is one, reach out to us. In fact, just yesterday, a family member of a veteran called me and said, look, I'm just a little concerned about this veteran. Would you do me a favor? And they're not violating in HIPAA or anything like that. They're just calling me and saying, would you do me a favor and take a closer look next time you see them? Reach out to us, their medical team, the primary care team. It may well be the nurse, or it may be the other healthcare provider team that is involved, even in the program. Let them know and say, look, would you do me a favor? I think he's having more issues than he's telling you, or she's having more issues than that they're telling you. Other thing I would ask is the caregiver say, can I come in with the next time you see the patient? Can I be in the room with them if the patient is willing to, the veterans are willing to have you there? That's a good opportunity to say, well, gee, I know you're maybe minimizing some of this, but I think you're having more of these issues, so you can explain more details to us. Because sometimes people will say something to us like, I'm doing perfectly fine, but at home, they're really, really disabled, right? So having the second person there kind of helps us to reveal the information.
And this will kind of be our last question. And it's kind of something that I would like us to kind of let our veterans know. It's a question we kind of got on a couple of our cards. It's something we see on our Facebook pages from time to time and that. So we see a lot of great compliments of staff going above and beyond and doing great things and taking care of our veterans. But every once in a while, we see where a staff member is just not meeting those expectations. Either they're not being quite as pleasant or cheerful or helpful as they can be for our veterans. I know we made a lot of steps in with some of our new hires. We're going to make some more steps. Can we just kind of talk about what we're doing to try and get our staff, when we see those things to do those, and what people who have issues or complaints with that, what they can do?
Well, I would say if you encounter an issue like that, we have our patient advocates we can talk to about, what happened and see what we can do with that. We do take those things seriously. We give it to the supervisor, who then, talks with the employee and takes whatever action needs to be taken. It's never good when somebody's rude or unkind or whatever. It's not acceptable. So we do want to hear about those. We are working through our Veterans Experience and our new Patient Centered Care Coordinator to work on a more customer service type training, and I think that's going to help us. We haven't had anybody in that role I've been here a year and a half, we've had nobody in that role. So this is a great opportunity for us to work on that. We also have our Veterans Advisory Board that you can tell these things to, and they can bring those to us as actions and things that they see, or you see, that we could work on to improve that. So I think we're gonna, there was something on Facebook just today about somebody who was rude on the phone. So Chuck, I know, always checks back on those, sort of his staff, to see where it was and what we can do about that and prevent it the next time.
Yeah, so please let us know. Like we said, we have several different means. Our VSA, you've got your local veterans service organizations, people with us regularly, our congressional staffers, people with us regularly. So please let us know, because we can't fix the issue if we don't know it's there, and if we want to address that. So that kind of takes us to the end of our time, and believe it or not, we actually got to every card I have in my hand tonight. So, there's a couple of personal things that I couldn't, probably delve well in here, but we'll see if those need some follow-up, and we'll get back with you on those. But we do thank you for coming out and joining us for tonight's town hall, and then if you were also at the hiring fair, we appreciate you coming out for that as well. Our next town hall is actually going to be offsite. It'll be October, I believe, 27th, in partnership with our Veterans Community. 26th. October 26th, in partnership with our Community Engagement Board. It's actually going to be over at Las Vegas PBS. So kind of like we did the hiring fair here today, fair with Las Vegas PBS, UNLV, some of our community partners, some of our career training programs. So it'll be an educational fair / Veterans Town Hall. Like I said, that'll be offsite October 26th at Las Vegas PBS. So we'll be blasting out the information on that. Also, please sign up if you have, if you want to get updates. We have little cards out there in front that have all our social media sites on there. Please sign up for those items on there, and you can actually get direct updates on that. So thank you.
Where is Las Vegas PBS?
I'll get you the address. It's down off the Flamingo, or City Chocolate Cannon. Yeah, it's in Flamingo. Yeah, Flamingo. So it's like Flamingo in the